So, hello and welcome. I've just realised I've said good morning. It's probably not good morning for all of you, but welcome to today's meeting. I'm Kate Wall from Beta Technology in the UK. We are a partner in the Bump2Baby and Me project, and I will be your host for today's discussions. So, for those of you who have not joined one of our forums before, Bump2Baby and Me is a 5.5 year project funded by the European research programme Horizon 2020 and Australia's National Health and Medical Research Council. It was delivered by an international consortium of partners. The project undertook a randomised controlled trial to test a novel healthcare intervention during pregnancy and the first year after birth. The ultimate aim was to provide policymakers, healthcare decision makers and health service commissioners with a cost-effective, evidence-based healthcare intervention to help prevent maternal and child diabetes. Throughout the project, these regular forum meetings have brought together policy and health stakeholders around a related topic or a discussion or challenge. So the topic for discussion today is engaging with mHealth, shaping the future of maternity care. We hope to not only raise awareness of the project, but also gather stakeholder input, get to know each other, and exchange information of mutual interest. So joining us today in the audience, we have international stakeholders representing academic, intermediary organisations and regional health representatives. So before we get started, as always, there's just a little bit of housekeeping to run through. So just to make you aware, for our future reference, this webinar is being recorded and transcribed. The recording will be publicly available after the event. If I could just ask all participants to remain muted unless invited to speak, please do feel free to leave your cameras on, especially if you are speaking in the question and answer session. You will be able to ask our speakers some questions after all the presentations are finished. We'll open up the floor at that point for a more general discussion. So if you would like to ask a question at that point, please feel free to use the chat function, or you can use the raise hand emoji. If there's questions in the chat function that you think, oh yeah, I'd like to hear the answer to that, you can use the like function, because any questions that seem to have a lot of interest, we can go to those if we're limited on time. Or any other comments or observations you can pop them in there as well. So the aim is that this is an interactive, informal networking event. That doesn't always feel easy, I know, when we're on a virtual event, but I'm sure we'll all get involved and make the most of it. So please do use this session to raise any questions, share your experiences and knowledge, and of course, introduce yourselves to fellow delegates. So today I'm very pleased to welcome our 4 presenters. Each presenter brings different insight and knowledge related to today's topic. Firstly, I would like to introduce our project coordinator, Associate Professor Charlene O'Reilly. Thanks, Charlene.
Super. Thanks very much, Kate. So just in terms of an update relating to the project, the gestational diabetes is the reason behind the project's formation. So a diagnosis of gestational diabetes generally comes out of the blue for the estimated, say, for example, in Ireland, 7,000 plus mothers that are affected every year by this complication. At the National Maternity Hospital in Holles Street, there are more than 8,000 births each year, and the staff expect to see about 20 newly diagnosed cases of gestational diabetes each week. This, however, is lower than the global averages. And as you can see here, it's about 1 in 7 at a global rate. And in some populations, it can be at least twice this, so about 1 in 3. So the reason we're primarily interested in gestational diabetes is not only because it has significant complications around the time of birth, but also that women who develop gestational diabetes are much more likely to develop type 2 diabetes, with about 50% or 1 in 2 women developing it within 5 to 10 years. And that means that the risk for these women is flagged earlier in their lives than, say, for example, older adults. We also know that the risk is even higher in populations who come from non-white European backgrounds, as well as those living with overweight or obesity. And speaking of overweight or obesity, this is another condition that means that the women are at increased risk of developing gestational diabetes, but also it's an increasingly prevalent condition for pregnancy. So now, for example, in Ireland and England, about 1 in 2 women enter pregnancy in the overweight or obese BMI categories. So it's not all doom and gloom. We do have strong evidence that suggests that we can reduce the risk of developing type 2 diabetes in this population. So we can reduce it by about 60% at 1 year and by about a third in 10 years' time for somebody who engages in a lifestyle health behavior change course of a program. So as a result, we put together the Bump2Baby and Me project. We became interested in seeing if we could intervene earlier in somebody's pregnancy and support them through that time and out the other side into that first year of life. So the Bump2Baby and Me randomized control trial occurred in Ireland, in Dublin, in Granada, in Spain, in Bristol in the UK, and in Melbourne in Australia. And we did a risk screening tool early in pregnancy around the first antenatal visit. And if women scored sufficiently highly, they were invited into the study. The study was randomized, so it meant that you either got usual care or usual care plus our intervention, which was the Bump2Baby and Me app, plus a personalized health coach. And that health coach supported the woman through early pregnancy right the way to 1 year postpartum. We collected data on things like maternal characteristics and outcomes from birth, as well as gestational diabetes diagnosis during pregnancy and other health outcomes for both mum and baby. So what was in the app? Well, the app provided support through the platform that Leva Healthcare have developed. And within that, the women can do activities which we know are important about health behavior change, such as goal setting. All our coaches were trained in health behavior change and came from a health professional background. The women then set those personalized goals, and they had access to other resources such as the health coach themselves, but also specifically developed literature that we put together in easy to use formats that could be delivered to the mum when they need it at the right time during either their pregnancy or the postpartum period. So in terms of the intervention study, it's completed now, and we had 72% retention of people once they came into the study and were randomized. So that's very good considering it was a very long intervention lasting about 18 months. And of those that were eligible, about half of them said yes, that they'd like to take part in the study, as well as within those that were screened. So it's a prevalent condition, and we were able to get the women into the study. So in relation to just, I know Kate mentioned that I was going to do a quick update, just to give you a kind of an overview of progress at the moment. So at the moment we have a paper under review examining the characteristics across the different countries of this at-risk population. The primary outcome paper is in preparation, so that'll tell us whether or not we changed weight status in our mothers, as well as other outcomes of interest in both the mums and the babies. We also have a paper that you're going to hear about from Senior, which is about engagement types. We have other papers coming out as well in preparation on infant development, and also a lot more than I can cover in this short period of time. Another key thing that we're working on is an implementation toolkit and a series of workshops. Each country is going to have its own bespoke implementation workshop that'll occur at a time and a place that suits that country. And we're developing a toolkit, as I mentioned, and that should be available at the end of the first quarter next year. And then finally, we've been doing training of future academics and people working in practice. So we've had already 2 PhDs awarded out of the programme, and one PhD thesis is due for submission in January. And you're going to hear some of her hot off the press findings. And we have another PhD in the area of medicine, and that's due for submission next year from Bristol. So I'm going to hand back to Kate, I believe.
Lovely. Thanks very much, Charlene. Really great to hear the latest on the project. So next, I would like to introduce you to the Bump2Baby UK clinical lead, Dr. Christy Burden. Thank you, Christy.
Thanks, Kate, and morning, everyone, if it is morning where you are. Yes, so I'm just going to present some work. So right at the beginning of the project that Charlene's described, we started by really trying to look across all the countries where we were undertaking the trial, and we wanted to see what the current care practices were for screening, diagnosis and care of women once they were diagnosed with gestational diabetes, and if that differed across the countries. So what we did is, back in 2021, we undertook a cross-sectional online survey, and that survey was undertaken from August 21 to November 22, and that was sent out to the countries that were participating in the Bump2Baby and Me project. And what we wanted to know was really wanted to find out what were the screening and diagnostic guidelines used, what were the risk factors used for screening if they were used, what the diagnostic tests used, and what was the care currently provided to women. And we sent this out to a sort of a variety of maternity healthcare professionals, so obstetricians, endocrinologists, neonatologists, dietitians, and diabetes midwives. And because this was undertaken at the time of the pandemic, we also asked if there was any changes to care practices due to the COVID pandemic. So we had 102 participants who responded to the survey, and this was spread across 63 maternity units in 3 countries, so in Australia, England, Wales, and Ireland. And when we really looked at where we had responses from, we had a very good geographical spread across the countries. So the first thing we asked them was what guidelines did they currently use for screening women for GDM to decide who was tested. And on the left there, that's looking at what they did in normal times. And then we asked them if they had any change in practice during the COVID pandemic. So as you can see, there were sort of single national guidelines used primarily in the UK and Australia, but there was a huge variance in the different guidelines used across Ireland. And when we came to ask them what happened during the pandemic, as you can see, there was an even greater variance in the guidelines used, and there's an increased use of things such as local protocols and COVID-specific guidelines. So the variance of what was used at that time increased hugely. So then we asked them, did they use for GDM universal risk factor screening? So universal screening everybody, or risk factor just testing people depending on certain risk factors. So as you can see, on the left is in early pregnancy, and then on the right is later at 24 to 28 weeks. So early on in pregnancy, most of the over 80% of the units reported using risk factor based testing. And then at 24 to 28 weeks, most Australian units then reported switching to universal testing. Ireland, as you can see, had a spread of both, and in England and Wales, they reported using selective testing, apart from one maternity unit. So then we asked them, so if they did use selective screening, so which risk factors were used? And as you can see from this graph, there's a huge variance in which risk factors were used to decide who was tested for GDM. And this varied hugely between units and between countries and at different time points. So consistently across most of the countries, previous GDM was used in early pregnancy. And later on, at 24 to 28 weeks, previous GDM or BMI and ethnicity were both used. So as you may be aware, in the UK, NICE guideline recommends early testing only for women with previous GDM, but there were some units that reported using other things such as BMI, family history of type 2 or previous macrosomia. So units often added additional risk factors, and that was very unit specific and often outside national guidance. And then we asked them what tests were used to diagnose gestational diabetes. And as you can see, again, there's a huge variance across all the countries and the different tests used. The most common test used was the 75-gram oral glucose tolerance tests. But even saying that, there's still a huge variance in what was used across the countries and at different time points. So then we asked them, well, what criteria did you use to diagnose GDM? And I think this is really interesting because, as you know, using different criteria could have a huge implication in who's diagnosed. So for the NICE guidance, our fasting levels are 5.6, but say, for example, the WHO or ADIPS guideline, that's 5.1. So that can make a huge difference in who's diagnosed with gestational diabetes. So most units in Australia used ADIPS or the WHO guideline, and most units in the UK use the NICE guideline. And as you can see, in Ireland, there's a huge variance in who was and which guideline was used, and this again increased in COVID times. So we asked them a little bit about sort of care practices. So once women were diagnosed with gestational diabetes, and again, there was a huge variance seen in this. So metformin was the first line medication used in England and Wales and Ireland, whereas insulin was first line medication used in Australia. And there was very sort of infrequent use of sulfonylureas across all the countries. Then we asked them a bit about when they sort of discussed an offer of birth, a recommendation of birth. And again, there's a huge variance across the countries and across the way that women were managed. So typically, birth was discussed or offered at 39 to 40 weeks in Australia for women who are managed just with lifestyle management with gestational diabetes. And in England and Wales and Ireland, this was usually slightly later at 40 to 41 weeks. Birth was discussed or offered for women who were using insulin to manage their gestational diabetes at 38 to 39 weeks, and this was quite similar across the countries. So overall, what we really took away from this survey was there was a huge inter and intra-country variability in the screening practices and care practices for women with gestational diabetes, and national guidelines were not always followed, and sometimes this was often decided at an individual unit level. So can mobile health at mHealth help in sort of addressing this challenge? So I think we're aware that mobile health is used now in healthcare and it can be used for a variety of reasons. So in terms of education, disease surveillance, treatment, clinical decision support, medical advice, or care documentation. And I think we're looking at how it's used currently for GDM. Most of the apps are looking at the monitoring of blood glucose or looking at lifestyle intervention advice, behavioural change. But what a lot of the apps currently don't do, or mHealth doesn't support currently in gestational diabetes, is looking at the whole picture from preconception through to postnatal care, and really looking at whether it can help to support screening for gestational diabetes, monitoring of growth, well-being, birth planning, things such as glucose control during labour, right through to sort of postnatal care. And so really it could have a future role in looking at really sort of standardizing and providing consistent care for risk stratification, education and clinical decision support throughout pregnancy. And I think future work should really focus on tools that look at GDM health throughout the pregnancy journey. So take-home messages. What we've really shown from our survey and our work is that there's a huge variation in care and practices for screening and management of gestational diabetes. And this really highlights a huge postcode lottery in care and can really lead to inequitable care and outcomes. And mHealth could be a potential solution in the future. It's used in other areas of healthcare, and it could be a way for providing more consistent care across the board and across the sort of GDM health care from preconception through to postnatal care. So thank you very much, and I'm happy to take questions and discuss this further in the discussion session. I think I'm handing back to Kate now.
Yeah, you are. Thank you. Okay, brilliant. Thank you, Christy. It was really important work that you've been involved with there, and thanks for taking the time to share that with us today. So now I would like to introduce you to Sine Benson, a research scientist at Lever Healthcare. So I'll hand it over to you. Thank you, Sine.
Thank you, Kate. Thank you for having me here today. Yes, I will present my work on digital engagement in the setting of this Bump2Baby RCT. And so our agenda for today is I'll take you through an introduction, a project aim and purpose, the method, and a discussion. As mentioned, this study is part of the overall Bump2Baby RCT, but then only takes into account the intervention groups. So those participants actually onboarded to the app, receiving this health coaching intervention. And so it's a cohort study of only the intervention arm, resulting in around 300 participants being included in this analysis. And so this depicts the general Bump2Baby RCT study design. So we can see that it lasts from pregnancy until the 1 year of age of after the birth. And then each column corresponds to the different components of the coaching program. But my analysis is only taking into account the data from the first year, so during the pregnancy period. Yes. And so what I will be analyzing is how the participants engaged with this mobile health coaching app. And so what that looks like is that they create a user and is onboarded to the program and start interacting with their coach. And then they can start interacting with the app as well, which includes logging goals and asynchronous as well as synchronous coaching through text and video. And then they also have access to these learning content and also a group feature where they can chat to each other. And so this interaction with the app is what I will refer to as the in-app features. So whatever they do in the app is prescribed to the database, and then that's the data I have available for analysis. So the idea for this project stems from previous literature that has looked into the relation between engagement level and outcome. And they have shown that there is a connection between a higher engagement level and an enhanced outcome. However, what it means exactly to be engaged is not very clear. Usually it's predefined by some sort of cutoff level into a highly engaged and low engaged group. But what we wanted to investigate was whether there were different types of engagement. And this would allow us to not only recognize those that are easily recognized as high engaged or disengaged, but also sort of the maybe in-between group that might not be high or lowly engaged, but just have like different ways of engaging. And if we could recognize them, then it might be easier for us to nudge them towards a higher engagement and thereby enhance outcome. So the question asked was if there are any patterns in the way the participants engaged in this digital setting. And so I've answered this looking into all these different variables characterizing how the participants interacted with the app. And so it resulted in 14 different variables under the themes of time spent in the app and their coaching interactions and their interactions with the group and how they registered goals in the app and also how much they use the content and learning pieces available in the app. And 14 different variables is a lot to sort of look at patterns within. It means we have like a sort of 14 dimensional space where we would try and recognize patterns, which is very, I mean, it's impossible for the brain to sort of comprehend. So what we wanted to do was to reduce those 14 dimensions into 2 dimensions, which is a space that we can actually recognize and comprehend. And we did so by using principal component analysis, PCA. And this can be thought of as sort of looking at the variables that contains the most variation and thereby information about the differences between the participants. So you can sort of think of it as if you wanted to separate apples from oranges, then shape would not be a very useful variable because they are both round. But if you look at color, then that would be a very easily separable variable to use. So you want to find the variables that contain the most variation about these differences. And once that was done, we did a clustering method to sort of look into this now 2-dimensional space if there were any specific engagement patterns between the participants that were similar and also dissimilar to each other between the groups. And so what I found was that the first principal component consisted of number of interventions, so interactions with the coach and messages sent to the coach, as well as messages read by the coach. So I named this first variable or the first principal component coach engagement, since they all refer to sort of coach interactions. And then the second principal component consisted of time in app, number of registrations, and number of goal types. And so I named this goal engagement. So we see that in the engagement, just describing the engagement, we have sort of these 2 variables that is coach engagement and goal engagement that you can then be either high or lowly engaged with. And so what it looks like in a sort of 2-dimensional space would be we have one axis with the coach engagement and one with the goal engagement, and then each dot sort of represents their engagement specific fingerprint. And then in that space, we looked for participants that were similar in engagement style and also dissimilar to the other groups. And what we found was these 3 clusters, so 3 distinct engagement types. And then if we look into where these engagement types are sort of placed in the coach and goal engagement axis, we see that we have the first group, which is sort of placed in the center, so not engaging that much with the goals and engaging a bit more with the coach, but sort of in the middle, which is why I refer to them as averagers. And then we have this blue group, which are highly engaged with the goal engagement. So I call those goalers. And then the last group, which are highly engaged with both elements. And so these are referred to as immersers. And what we can learn from this is that we see that the largest group is averagers. And so they rely mostly on the coaching support in the app rather than using all the other features and sort of active monitoring of themselves. And so putting this into perspective in this sort of innovative digital health coaching setting, it shows us that at least in this setup, it's still very important to keep the human component, as this is the one that the participants actually use the most in these in this coaching. And overall, the focus is on coaching and the goal features. And so maybe we should take into account that these are the preferred sort of variables to interact with. So maybe we could sort of redesign the app a little bit to take away some of the other features, or making them a bit different and making them easier for participants to interact with. And these engagement types are not just as simple as high and lowly engaged. And so this can make us recognize engagement types and thereby nudge to higher engagement without trying to make them engage. Like if you're in the goalless group, then maybe we don't have to make everyone engage with all of the variables, but we should just focus on making them engage more with the engagement style that they already have. And if we compare this to other work, we see similar results, that mostly this averages group is what represents most of the participants, and also that the coaching and goal features are the most important in a digital setup. And this study could be developed further by linking to engagement groups to their outcome, to actually see if there are any sort of the engagement groups that are, so to say, better than the other in terms of outcome. And we have done a similar study in LIVA on a different cohort, and what we found there was that there was a link between engagement and outcome in terms of retention time. So if you were more engaged, you were less likely to drop out of the program. And this could be used to tailor to the onboarding to specific engagement types. So if we could already from the beginning of the coaching recognize these different engagement types, we might be able to design the coaching and the program much more specific to your engagement type, and aligned with that, develop such features to align with the user engagement type. And then, of course, we should also include the postpartum part of this study to understand the whole journey of pregnancy for these women at risk of developing GDM, so that we can support them the best way possible all the way through, both during pregnancy and after birth. Thank you.
Brilliant. Thank you, Sine. It's a really fascinating topic. Okay, finally, I would like to introduce you to Liz McGovern, who is a lactation consultant and PhD student at University College Dublin. So thank you very much, Liz.
Thanks, Kate, and thanks for the opportunity to talk today. My area of interest is breastfeeding and breastfeeding self-efficacy specifically. I am going to be looking at levels of self-efficacy and breastfeeding attitude in the Bump2Baby and Me study, and looking at the associations with breastfeeding outcomes across the wonderful span of data that we have across the first year. But today I'm just talking about lessons learned from a scoping review that I conducted earlier. So self-efficacy refers to a belief in the ability to complete a task or reach a goal. So Bandora's self-efficacy theory would be the basis for the work in this area. And a lactation consultant in Canada in 1999 applied this self-efficacy model to the world of breastfeeding and created a structure, I suppose, a framework for breastfeeding self-efficacy, defining it as a person's self-belief in their perceived ability to breastfeed. So we know from the literature that people who have higher levels of self-efficacy in breastfeeding will go on to have stronger and higher breastfeeding outcomes. And we also know that it is a highly modifiable factor, so we can really work with it to try to enhance it along the way. So the literature will show us that it's influenced by many things. The knowledge that somebody has about the benefits of breastfeeding, their attitudes to infant feeding generally, which of course are formed from a multitude of places, their experience with breastfeeding, and that can be themselves if they have children already, but it may also be people in their world, you know, their sisters, their cousins, their friends, their colleagues, and being aware of experience that people have had that they know in breastfeeding. The views of important people in their lives. So obviously their partner and their immediate family will come in here, but their in-laws are also in that picture as well, and colleagues and wider people. And another aspect, and healthcare professionals, of course, will be important people in their journey of breastfeeding and how that's influenced. And another area in the mix is societal norms. And so for a country like Ireland, where we have among the lowest breastfeeding rates in the world, and many would say we live in a formula feeding culture, this is an aspect that is important to consider in the mix as well. And in terms of somebody's confidence and the ability to maybe enhance their confidence, we need to think about all of these things in having an interaction. So I suppose, why am I focusing on the prenatal period? Well, I mean, to put it the most simply, it gives us a huge extended amount of time to work on enhancing this level of confidence. Anybody's confidence in any area is going to be possible to increase, but it takes time. So coming in after the baby is born, and you know, when really you're dealing with sleep deprivation and quite a big learning curve, particularly for first-time parents. It's quite a cluttered area to be coming in. Whereas if we can enhance it earlier in pregnancy, it gives us more time to kind of embed an improvement in the area. So I am looking at that aspect of prenatal the prenatal time period. But in the literature, it appears that it is an underserved area, that the majority of work is in that postnatal period. So I decided to do a scoping review to really explore and map out what has been done in the area prenatally. And specifically, I looked to identify and describe the theoretical frameworks that were used to underpin the research that was done in the area, looking at what measurements were used to assess breastfeeding self-efficacy, and then looking at what interventions were used and the impact that they had on breastfeeding outcomes, whether that was the initiation of breastfeeding immediately after the baby was born, or duration or exclusivity. And the paper was published in September and is available at that link I've just whipped by. So interventions wise, then, in the scoping review, I had 184 studies, and 84 of them were intervention studies. Timing wise, the majority were delivered solely in the prenatal period, but 40% were delivered straddling both prenatal and postpartum. However, when you look at when the interventions happened a little bit more deeply, they commenced mostly in the third trimester, and most of those were in the mid to late trimester. So again, there's a bit of a gap there in terms of earlier in the prenatal period. In terms of theory, the recommendations, both in the literature and in the clinical guidelines for breastfeeding, are to try to enhance, to try to address things early, but also to make sure that we're learning from the people who've come before us and the theory that outlines the area that you're working within. So unfortunately, only just over half of the interventions in this review had used self-efficacy theory to plan out their intervention. But it made a difference. This aspect of both timing and theory use made a difference to the results. I was able to explore the outcomes of the interventions, and the outcomes were split into either self-efficacy scores itself, or breastfeeding outcomes like initiation and duration, or maybe some intervention studies looked at both outcomes. So I categorized the interventions into groups that either had a high or medium level of theory use in their design and their rollout of their intervention, or ones that had low or no theory use. So for breastfeeding self-efficacy scores, there were 22% more studies that had high or medium levels and that had statistically significant results and improvements in this area. So 85% versus 63% of studies that had low or no theory use. And then in terms of breastfeeding outcomes, so there was a 32% difference between the two categories of studies. 86% of those with high or medium had statistically significant improvements in the area. The other aspect with timing was the longer the delivery, so spanning the periods, the more frequently the studies reported statistically significant results. So in breastfeeding self-efficacy scores, there was a small enough difference, but still higher for those with with the longer delivery. And it was, again, much bigger gap between those that spanned both periods, and then those who delivered just prenatally in terms of the breastfeeding outcomes. So it makes a difference in terms of theory use and the timing. So in terms of the interventions then still, and looking specifically at Bandora's breastfeeding self-efficacy theory, there are 4 antecedents and areas that are covered off, I suppose, and suggested that these need to be in place for the full breadth of self-efficacy theory to be addressed. So performance accomplishment is generally in terms of having experience and accomplishment doing the specific action that we're talking about. But for people who maybe it's their first baby, they obviously can't have direct experience at it, but they can, in the field of prenatal self-efficacy, what is addressed here is looking at other areas where they have accomplishments and mapping them to how they can be applied to breastfeeding. Vicarious experience is seeing the action of the activity being done. So seeing other people breastfeeding, and again, in I suppose, if somebody is in a formula feeding kind of culture where lots of people around them are formula feeding, they may not be seeing people breastfeeding much. So that's important in there as well. Verbal persuasion is an area where a lot of people can, I suppose, be involved in that in terms of healthcare professionals, but also the people in the person's world. So it's important that we're bringing along people in that side of things as well. And physiological and emotional responses is really a measure of somebody's resilience and response to when things maybe become a bit stressful. What are their capacity skills like for overcoming that? So that's the theory around it in a very whistle-stop way. And what I did was I looked at all of the intervention studies and I categorized the components that were delivered across the studies. So 97%, almost all of them, delivered some level of education in whatever format, whether that was written education or in a lecture or presentation style or workshop or things like that. Encouragement and support, again, 82% of the studies all provided this, and it makes sense that it would be in there, that there would be a support and encouragement towards breastfeeding and that nudging idea that's already been covered. Engagement is an area that in theory could come under encouragement and support, but I felt it required its own category because it was really things like active participation with the mothers in the studies, in that it was really actively getting into problem solving, looking at what might go wrong and how might you go about that, motivational interviewing maybe. So it was a step above just the kind of, these things are here for support and you know, encouragement for breastfeeding. So it was a different level in my eyes. Then vicarious and kinesthetic learning. So vicarious is the seeing by doing, and the learning by seeing, and kinesthetic is learning by doing, really. So some studies will have had you know, a peer come in and breastfeed within a session, an antenatal session. The kinesthetic side would be the use of, you know, dolls and positioning and demonstration and reverse demonstration of things like that. And then the last area of, actually just to mention that only half of the studies used vicarious methods in their approach and their design. And then the one that had the least coverage was 26% incorporated the person's social support circle. So in terms of the verbal persuasion and also the physiological and stress responses of when things don't necessarily go right, it is very strong in the literature about having the support circle of somebody also involved in the process of bringing them along in terms of breastfeeding preparation and support. So only 26% of studies had that. So in terms of the outcomes, then I've already said that the two types of outcomes were self-efficacy scores themselves and breastfeeding outcomes. So looking at those 5 categories or components that I extracted from the studies, when studies used 4 or 5 of those in their intervention design, they had higher results, or more. There were more frequent reports within the study. So more studies reported an increase in self-efficacy if they used 4 or 5 of the components versus those who used 3 or fewer. So again, you can see the self-efficacy score, there was a nice big difference there, but even more so in terms of the breastfeeding outcomes. So it definitely makes a difference, the level of theory use that's there. So I suppose just doing a quick lessons for health engagement from that would be within the content of the intervention itself to use what the people before us, both in research and clinical practice, have learned and the theories that are underpinning that. So using the theoretical multi-component aspect to guide the intervention design, and also planning when the intervention is being planned to actually make strong connections between what the theory is and what the intervention is. Like the studies that showed a really strong link of having demonstrated that they really thought about it, they really mapped the different aspects of the theory and those antecedents to what they were doing in the study, it made a big difference. And in terms of timing, I suppose early intervention to maximise the time for whatever, depending on what the mHealth aims are. Consider the role of the measurement tool was another thing that I suppose came from my review. Using a measurement tool early in pregnancy can identify the issues that for breastfeeding are showing people who are at risk of early cessation. They can guide a tailored support, and they can even raise awareness to what the area is that you're looking to intervene on. And then lastly, just to say that the longer the duration, the better the results. And so if an mHealth intervention can span prenatal and postnatal periods, it has a better result. So that's me. Thanks for your attention.
Brilliant. Thank you very much, Liz. And thank you once again to all the speakers for sharing your knowledge and information this morning. So I'd like to now open up the floor to any questions that you've got for our speakers, or just invite an open discussion.
Is some questions in the chat?
Yeah, I'm just bringing that up.
Yeah, I ask something. Hello.
Hi there. Sure, go for
Hi,
it.
I'm Maria. Thank you so much for the great presentation and the results that you shared. I'd like to ask, I think my question goes mostly in the third speaker or the second, regarding the engagement and the features that could be included in the app. And you mentioned that might be interesting or helpful to have a screening tool for the gestational diabetes. And I'm wondering how safe this could be, and or how we could make it safe. Because if we just ask people to self-screen for their risk on gestational diabetes or any other condition, this might pop up different risks. So I'd like your opinion on this. Thank you.
Do you want me to answer that? Kate?
Yeah, thanks, Christy.
I think the thought is it wouldn't necessarily be like self-screening. It could be something like, you know, clinical decision support for a healthcare professional. So it wouldn't necessarily be done necessarily just by the woman or the patient, but it could be something to help guide and support the healthcare professional. Because what we really were looking at in the survey is that obviously the care is very inconsistent, and maybe could it be a way of making the care more consistent and more standardized. But that would be more in terms of a clinical decision support for both the healthcare professional and the woman, so it wouldn't just be relying on self identifying.
Yeah, and I suppose if I could add to that, Christy, in Bump2Baby and Me, we had that screening being delivered by a healthcare professional, so that the woman could have a conversation about what that risk actually means and what her options are around it. So we had a standardized script that our research team used to have the conversations with the women, because it absolutely needs to have sort of safety bumper rails around it, because you don't want to just tell somebody they're now at risk and then, you know, okay, bye now, you know, make your own decisions. You need to support somebody in knowing that there is something out there for them to help address that risk, and that it is possible for them to engage in that.
Brilliant.
I think you're right. I think you're right. It needs to be really well considered, because actually it couldn't, you know, it couldn't just be sort of self-report, because that might lead to even more inconsistencies potentially.
So we have another question here from Jacqueline Yates. Thanks for your question, saying, I'm interested to know what others do for testing from 36 weeks. I'm a midwife leading on prevention across South Yorkshire.
I think there's been huge national and local discussions about this. I think the bottom line at the moment is that there's no evidence to guide what's done at this stage. So I think at the moment, I don't think we covered that in our survey, but I think I know at the moment that's very different across a lot of units, and probably if we asked all the units across the different countries, that would be even more consistent, because I think there's no national guidance to guide what's done at this stage.
Okay, thank you. Kimball asks, how large was the data set for examining the engagement patterns, given AI has been used for clustering? I'll throw that one to you, Sina.
Sorry, just had to unmute. Yes, so it consisted of the whole intervention group, which was 340 participants, I think. And yes, so it's true that it's a slightly small cohort, and yeah, the study would definitely have to be expanded, but it still should be enough to at least have some statistical evidence.
Well, thank you. And we'll just take this final question here in the chat. Apologies if I missed it, but was the mHealth platform co-produced with women and healthcare professionals?
I might answer that.
Yes.
So I suppose the Leva platform itself has been developed out of the need and want to use something like this within healthcare professionals. So the founders of Leva are medics in their background, working in general practice and similar areas, and they did develop up the application functionality with users. But because the app can be used across different health conditions, it's not been specifically as a platform developed just for gestational diabetes. It's across health. It's actually the same platform that's used as part of one of the offerings within, say, the NHS's diabetes prevention program, as well as diabetes management. So, you know, it is a widely used platform. And then in terms of from Bump2Baby and Me, we used evidence from several different trials that gave kind of our bits and pieces that made up the journey. And those pieces of data, information and learnings had been through working with women, and there was also qualitative interview work around what women want in terms of seeing themselves in materials, etc. So while we didn't have a bespoke group of mothers working to co-design the materials, we did use the learnings from data that was generated from women. And we actually have also done, say, systematic qualitative review to pull that information together around what women actually want from mHealth interventions.
Brilliant, thank you. So that's all the questions in the chat, and we are nearly out of time. So I'm going to wrap things up now. So thank you for those questions, and I'll just make a last few concluding remarks. So going forward, we would very much like for you to all keep in touch with the Bump2Baby and Me project, and you can do this in a few ways. So you can complete our feedback form. There's a QR code there on the screen, or I think there's a link being put in the chat if you prefer. We do appreciate your feedback, and we will use this to shape future events and make sure they are of value to you. Also, on that note, in terms of future events, please do look out for our upcoming implementation workshops next year. We'll let you know the dates when we've got them. Here we are going to be sharing the key messages from the study and showcasing that toolkit that Charlene mentioned earlier. So just stay in touch with us if that's of interest to you. You can also follow us on Twitter or LinkedIn, and you can sign up for project updates and policy related developments via the website. So finally, I'd like to say a big thank you to all of our speakers, for everyone that's joined us this morning. We look forward to our Bump2Baby workshops, and I'll let you get on and enjoy the rest of your day. Thank you very much.